So, good morning. It is now 10 a.m. on Monday, the 30th of January 2023. This is the first formal meeting for maybe a couple of months of the Health and Care Overview and Scrutiny Committee. So I hope councillors are well rested and ready for what lies ahead in 2023. So first of all, welcome councillors, and equally to our guests. Thank you, both virtually as well as in person. I am your chair, County Councillor Jeremy Pert. I'd like just to make a couple of introductory comments and remarks, if I may, please. First of all, welcome to David Pearson, who has taken over as the chair of the Integrated Care Partnership, as the interim chair of the Integrated Care Partnership. So welcome, David. I know it's only a step up from being the vice chair, but look forward to a period under David's stewardship. And second of all, between meetings, I'm sure members will have seen across the press the West Midlands Ambulance Service and the delays to patient transfer with many patients on the back of ambulances for a prolonged period over Christmas, particularly with Royal Stoke. And I think anyone watching that will have been concerned, extremely concerned and dismayed. I have to say that committee members who have been with us for a while will be aware that we've been scrutinising the system pressures for at least the last 15 months. I think it at least demonstrates that we have been focused and working on and trying to resolve some of the things that concerns our residents most. Clearly, I hope that some of the changes that have been made recently will improve the situation, albeit in this case, the early onset of flu was a significant contributory factor to the system being so stretched. But on that point, I would just like to undertake a lessons learned exercise probably in May or June of this year, tied to a review of the winter plan going forwards for next year. And ensuring that any changes that have been made have been hardwired into the plan going forwards. I think to do anything else would be premature, particularly given the committee time we've had on system pressures to date. We can pick that up in terms of forward planning, but I just thought it was an important point to make. So let's move on to today's agenda. May I remind committee that today's meeting is being recorded, and for those who want to watch it back, they can be found on the County Council's website. Equally, the recording is being beamed live, and there will be a cut-off 20 seconds after the equipment has stopped. All voting committee members are in person, can I ask our guests, first of all, to accept that members have read and digested the papers provided and to restrict their opening comments to 5 or 10 minutes, depending on the item. And second of all, that we as committee focus on the tangible outcomes for residents of Staffordshire. On that basis, let's move through into the agenda proper. First of all, apologies. Zach.
Good morning, Chairman. I've received apologies from Councillor Wilkes, Councillor Abrahams, Councillor Hood, Councillor Jay and Councillor Maycock.
Thank you. Understand that. Item number 2, declarations of interest. Do we have any declarations of interest relevant to this morning's agenda? Anne Edgeler, please.
Good morning, everyone, and thank you, Chairman. Yes, I'm the Partner Governor of the Midland Partnership Foundation Trust from the County Council.
Thank you. Anne. Richard.
A non-pecuniary interest in the George Bryan item. Family member had been a patient in there, just to put that on record.
Thank you, and you've been very consistent with that, so thank you for that. Any other declarations? No, I will move on. Can I just confirm for the minutes that we are quorate, please? That's a nod and a yes, so let's move on to item number 3, the minutes of the meeting of Monday the 28th of November 2022. With the exception of just correcting Tracy's name, which we've previously discussed, can I confirm that the minutes are a true and accurate record? Just let me take Janice.
Thank you very much, Chair. Good morning, everybody. Just a note, on the last meeting, there was a brief update given with regards to the women's health strategy, and that's not seen on the minutes. And the importance of that is that there was an undertaking from that session that they would go and have a look and try and pursue the responses that we're still awaiting with regards to the emails that were sent afterwards. So if that could be added, that would be much appreciated. Thank you, Chair.
Thank you. Absolutely right. Remember that conversation vividly. So can we, between yourself and Zach, just come up with something that is suitable, which reflects the discussion? With that other exception, are we happy to approve the minutes as a true and accurate record? Lots of nods. So, Anne, you're proposing we accept them. Is someone going to second them? Janice, thank you. Let's move on. So that takes us to item number 4, and welcome to got completely different names here, but welcome to Paul and to Helen, who are going to take us away, I think. No? So Paul and to Lynn is going to take us away. So Paul, I believe you're starting, so you've got a presentation for us.
Yes, I have. I think Claire's going to show the presentation, Claire, for me, the wonders of modern technology. I can present here and the slides are up there. So just very quickly, as you said at the beginning, Chair, I'm going to assume that the paper's been read. I'm just going to take you very quickly through a presentation. Claire comes on. So first slide is just an overview. Slide 2 is just reminding us of the Staffordshire and Stoke-on-Trent communities, which we come on to there. So it's a reminder that what we're talking about today is the Integrated Care Partnership, which covers all of the communities in Staffordshire and Stoke-on-Trent, of which the ICB, which Lynn and I are both employed by, is a part, but only one small part. So this is an integrated care partnership strategy. Just put up on the slide, sorry, go on, Claire, next one. So on the next slide, you'll see written up on there is our vision and the purpose, and you will have seen that in the papers that you've already read. So we go on to the next one and look at why do we need to change? Why do we need to do things differently? The first one is the national direction. So the Health and Social Care Act 2022 gives new statutory powers to the Integrated Care Board and Integrated Care Partnerships. And then we have a number of local challenges, opportunities that we've put down on here. Demand is growing. We know that COVID is still with us. We've also had flu with us over this winter. Services can tend to be or appear to be fragmented with multiple organisations involved. The workforce is weary, and that's our collective workforce right across the whole, from NHS, social care, local authorities, voluntary sector. Everybody is really quite weary now after 3 years of COVID and the way that they're having to work at the moment. We do have some key shortages in manpower across the various specialties. Our financial position for the system is improving, but it is still very, very challenged. And again, that applies both to NHS, local authority, and our voluntary sector colleagues as well. We're working in a really challenging financial scenario. And we recognise that some of our communities do face barriers in accessing the services. So we can go to the next one, Claire. The next one really sets out the position, I guess, if we do nothing. So this is the bit about demand growing, population changing. So on the left-hand side, we've got the populations at the moment in terms of particular groups. And we're looking at a 15-20-year change over that period from 2020 to 2030. If we do nothing, we will have 14,000 more people with cardiovascular disease, in that 10 years. And you can see all the way down that if we do nothing, we will be seeing more and more people coming through with long-term conditions. That will put huge pressure on all of our services, both NHS, local authority, etc. So we have to do things differently. We've really got to work in a different way. The next slide, Claire, just reminds us of the change to the system. So the whole of that slide is the system, the integrated care system. We've got three main parts to that. One is the Integrated Care Partnership, for which we are all part of. On the left, you can see the Integrated Care Board, which is the organisation responsible for the NHS spend. Essentially, the ICB is the successor to the 6 CCGs that we had before. And then on the right-hand side, you can see the developing place agenda at upper tier local authority level and our provider collaboratives. So we go to the next one, Claire. You will have seen this in the papers, so I'm not going to run through this in detail. This is essentially the brief that we have for our ICP strategy. And you can see it starts with the national requirement and then moves through the reasons why we need to do this and how we need to look at integrating our services, using a population approach and driving that change. And I'm just going to go now quickly through three levels of issues that we need to look at. The first one, for those who were listening to Radio 4 this morning, you'll have heard the Health Minister talking about the latest initiative to treat more people at home, to drive down what we've put on here, the long waits for ambulances that have been seen over the last year or two, our crowded emergency departments, long waits for elective care, difficulty accessing primary care, and people saying that they can't see their GP when they need to or they want to, and the difficulty with social care. So those 5 things we feel is what we're hearing is absolutely what's top of the agenda of our local residents at the moment. The next slide, Claire, highlights the existing shared priorities that we have. So I know that you will probably want to talk about the juxtaposition between the ICP strategy and the health and wellbeing strategies that we already have at the upper tier local authority and also some of the lower tier local authorities. And you can see on there some of the existing shared priorities that by working together with local authorities, we've put together that these are the key things that are coming out of the health and wellbeing strategies and that slightly lower level. And you can see on the right-hand side of that slide where we're emphasising that the strategy is built on the NHS long-term plan, Staffordshire County Council and Stoke-on-Trent City Council strategic priorities and the 2 upper tier authority health and wellbeing plans. So that sort of brings it together as to how we're doing that. We go to the next one, Claire. And then we have what we call the 20+5. So looking at the bottom, you can see we look at the communities in the most 20% most deprived areas of England. And that has got to be a focus for us to look at that, which is both geographical and looking at different communities. But then we look at, if you like, what we call the plus group. So what are the other groups that we ought to be looking at that maybe have barriers to accessing healthcare, social care and other services? And we've put some of those down on there. It won't have been exhaustive, and that's part of what we want to cover when we do the engagement on the strategy. We'll go to the next one, Claire. You'll have seen coming out, I apologise, that's quite difficult to see on there, but the essence of that you will have seen coming out of the paper that you had. So essentially what this is showing across the top is that in parallel with your health and wellbeing strategies, we'll take a life course approach. So we will look at those 5 key life course groups, looking right across at where we've got things to do across the life course. And then what we've done under there is to put on the left-hand side those high-level issues that we were just talking about, ambulance waits, emergency department waits, elective care. And then on the right-hand side, the 5 Ps approach that you'll have seen in the paper that we did around prevention, productivity, personalised care, etc. And then underneath, the 4 ambitions of the integrated care system, which are to improve population health, etc. So trying to just put in a schematic what that overview is of the strategies we go forward. We go to the next slide, Claire. So this slide is just setting out how we need to move towards system transformation. So what we're trying to do is here to acknowledge the challenges, but also focus on the strengths that we have locally. So we've got lots of challenges within the health and care system, but then our communities and our local residents are the strength that we've got. And we absolutely need to make sure that we build on those community assets so that we're taking a bottom-up approach to much of this rather than a top-down approach. So, Chair, I'm just going to move on now to the last slide, if that's all right, is just to take you through, and I've put 5 questions up there, which you may or may not want to consider. But they're what we would look to do when we go out and meet with stakeholders, priority groups and so on, is do you think those top 5 that I went through are correct? Do you then think the ICP ones are correct with our partners, the health and wellbeing ones? Then on to the Health Inequalities Plus groups. Have we missed anything? Anything you would like us to engage with specifically? And would you like anything else, any more information? And I wasn't going to do any more, Chair, if that's all right.
Thank you. Really helpful. Some nice slides as well. Are you going to share the slides formally with us?
Yes, we can.
So that we can put them on the website and members can come back to them?
Absolutely.
I took one of the very early slides as being very much... sorry, can we leave the slides up so that members can see what the 5 questions were, please?
Can you put them back, Claire? Is that all right?
But I was going to say one of the early slides, I think, demonstrates a burning platform and putting it in sort of stark terms. And maybe that needs to be more often communicated because, you know, I think we need to see things in that widest context. Can I just take committee's liberty just to ask the first question, because it goes to sort of the health and wellbeing strategy. And you referred to it. What is the crossover and the difference between the strategy of the ICP and the Health and Wellbeing Board? Because there's a real danger that there is lots of people who talk about big strategies and there is a crossover but not an ownership. What do you see as the difference, please?
If it's all right, Chair, I'll start off and then I might bring Lynn in because Lynn's been involved in some of the development of this and how we've developed that. So my view in essence is that the health and wellbeing strategies of the health and wellbeing boards focus on the place. So the health and wellbeing strategy for Staffordshire focuses on Staffordshire. The one for Stoke-on-Trent is focused on the city. We then have a number of lower level health and wellbeing strategies as well. I know you're not talking about them, but there are districts and boroughs that have health and wellbeing strategies, and also our NHS organisations are developing their own health and wellbeing strategy for their organisation. So I see those as covering particular groups and particular areas. The ICP strategy is particularly looking at the whole of Staffordshire and Stoke-on-Trent, so taking away all of those boundaries. It's taking that overarching view. We view it as being supportive rather than another top-down strategy. So it underpins those health and wellbeing strategies and reinforces them, but it is particularly looking at health and social care and the role of the NHS in that. Health and wellbeing strategies, I think, come from the other direction and look particularly at the role of communities and local authorities, of which the NHS is a partner. So I think they're coming slightly different angles. We have worked very closely with the local authorities up at here. The ICP is jointly chaired, as I think we've said, by David Pearson, the chair of the ICB, Councillor Alan White, who is the leader of Staffordshire, and Councillor Abby Brown, who's the leader of Stoke-on-Trent. So we've very much got that triumvirate chairing the ICP. And I think if I hand over to Lynn, she'll explain how the local authorities have been involved in the working of the strategy. Is that right, Lynn?
Yeah, thank you. Just in terms of the difference for me, this is a different approach for health particularly. The life course approach is it's not new to the NHS, and it's something that local authorities do all the time. And it's relative to people. We are born and we eventually die. So it's very familiar to local authorities. But for the NHS, we tend to focus on body parts, really moving away from that and looking at people and what people need in their communities. So that's the first thing. In terms of what else is different, it's the integrated part of the care strategy. It's how we align all of our priorities, not just across health and care, but our other partners. So, for example, the fire service around the table, the police and crime commissioners around the table, and it's how we get everybody pulling in the same direction, focused on the priorities that we've all identified, and thinking a lot more about how we focus on prevention. The 5 Ps are really important. It's a different approach for us in terms of everybody looking at the assets in the communities, how people can be more responsible for their own health. So for me, the approach is very different than what we've been before.
Yeah. And I think in summary, Chair, the strapline that we've used in it is that the aim of the strategy is to make the overall impact greater than the sum of the parts. So it's about bringing all of those parts we talked about together and making the impact greater.
Thank you both. I guess in response, I'd say it's quite a complex area. And I think we need, particularly if we're going to get residents to buy into what's there and to give us their input, we need to try and make things as simple as possible, because some of that's quite sort of complex in terms of overlap. And part of that might be about clear accountabilities, who is doing what, when, and who's responsible, and what is the outcome. So that any of those strategies, excuse me, any of those strategies that you've referred to don't become just talking shops and people just attend the meetings, rather than actually change the overall impact on people's health. So that's not a criticism of the ICB or anyone else's strategy, but I think for them to be successful, there needs to be clear demarcation as to who's doing what, where, when and how, and for what benefit. I'm going to go to Keith, because I think Keith was up first, then Anne, then Janice. So Keith first, please.
Thank you, Chair. Yes, for me, as you say, there's about 3 different layers of strategies by the sounds of it, which yourself found difficulty in sort of explaining to some extent. If that's difficult to us, how's it going to appear to the rest of society and all the people we represent? So I do think there's a piece of work that needs to be done in terms of trying to make sure that people understand what you're trying to achieve and everything else. So I've got 2 questions. The first one is, how do you think you're going to influence the idea of employment, environment and housing, which is written into your strategy at the moment, through this strategy? Because there's no detail on that as such. I know that some of it can be the place-based approach, which is what's been happening within our own county council approach and all the rest of it. And then secondly, on back of that, you say it's access to services, and then there's a limitation on resources for finance and people. So I can't see how you're going to be able to get the resources, get the people, and then be able to influence those 3 things without there being a little bit more detail in terms of how you might want to do that. And then secondly, going back to my original point, and it's been pulled up by the chair as well, how are future engagements outside this body and across the whole of Staffordshire and Stoke, how are you going to communicate this approach and this strategy to others? I think that's the only thing that I would think that we can do at this stage without there being more detail about how you're going to be able to produce strategies and ideas and tactics, if you like, going forward to influence employment and housing, of course. You'd have to start talking to planning and things like that. So it's quite a long way out of your remit that you've been involved with in the past. So I think those two questions are for me at the moment. Thank you, Chair.
I'll do my best, if that's Chair, to go through that. You're absolutely right. It's complicated. It's a crowded playing pitch with lots of people in there doing things, lots of opportunity for crossover, and that's what we're absolutely keen to avoid, is any duplication, any crossover, because as you rightly say, we're limited with finance, we're limited with resources. We're working on the basis that we will have flat cash. So we're working on the basis that there is probably in spending power, no increase in our spending power. We may get increased funding, but with inflation and everything else that goes with that, it is likely that we will be fairly flat with what we've got. The second one is that we're assuming that in the short term at least, we'll be fairly flat in the resources we've got in terms of manpower. There are no magic solutions to finding more nurses, more doctors or whatever. Going forwards, yes, we can do things differently over the years. So that's the sort of basis we work on. What will happen with this strategy? The strategy will stay very, very top level. From this, what we have to produce, so we've got a statutory mandate to produce this strategy by the end of March. Absolutely recognise that that will be a step in the process, because doing the engagement and getting things all signed off, everything done by the end of March is not going to work. So we recognise that the end of March is a stage in this process, and the work and the engagement will go on with communities, with stakeholders after the 31st of March. What we also have to do by 31st of March and going to the beginning of next year is create what's called the 5-year joint forward plan. So comes back to what the Chair was saying before, and that's where who will do what will come out of that. So the strategy will translate into a plan which will have the outcomes going forward over the next 5 years. In the integrated care system, we work in, at the moment, 7 portfolios. So we've got a portfolio for urgent care, portfolio for primary care, etc. So we work in those portfolios, and it'll be the responsibility of those portfolios in which we've got all stakeholders involved. So local authorities are involved in those, and in fact helping to lead some of those. So we'll work through those portfolios and develop the plans as you go down the organisations. We'll also be looking at each individual organisation to produce their plan as to how they are going to deliver against that overall strategy and the overall plan. And that's where we'll come into what is it that the NHS can do to help with employment, with housing, but also how do we engage as the NHS better with local authorities, where sometimes housing is the solution to the medical issue. So how do we work better? At the moment, we have too many handoffs, too many organisational barriers, and people get lost between the two. So what we're trying to do is to say, how do we break some of that down? How do we work together, and how do we do things that puts the resident first, not the organisations first? Now, that's a big ask, and it's a big culture change that we've got to do. Can I hand over to Lynn, who'll just talk a little bit about the second thing, where I think you talked about the future engagement, how we would take that forward.
Thank you. I think for me, what we need to do with the strategy is outline what will happen if we don't do anything. So we need people to adopt a different approach. So that's individuals taking more responsibility for the health, organisations and the workforce thinking very differently about people and thinking about the 5 Ps, prevention, person-centred care, when they're interacting with patients and thinking about care pathways. So we are doing a number of engagements events with focus groups. So we really want to reach out to those seldom heard groups that we just identified in the presentation. We have a survey that we're about to publish that's quite different in its approach. And what we want to do in terms of the questioning is not look for the problems and the issues, because we know what they are. Look what needs to be done differently going forward, what works well now, what doesn't work so well. So we're trying to get solutions from our communities as well as trying to solve the problems for them. We want our stakeholders to adopt the 5 Ps in their own strategy. And so the intention, the integrated care partnership would flow through everybody's strategies across the whole system, from fire to health to care. So it's that integrated approach that's really different. We need to have a discursive conversation with organisations so they can start thinking about, well, what does this mean to me? What does my organisation need to do differently going forward? So as Paul said, the engagement will be ongoing. We have to produce a strategy by the 31st of March, but in order for it to be meaningful and relevant, that will continue well into the summer, and we'll continue to adapt and evolve our approach.
Thank you for that. All I can say is I think your answer to the first question, it's brave. I can't see how you're necessarily going to get to those points relatively quickly, as you say, with limited resources and everything else. So I'll be interested to see how it comes back to this committee, which I'm sure it will do, in terms of how you're going to try and achieve that. So I'll be quite interested to see how that's going to work on the place-based element of that. In terms of engagements and everything else, obviously there's districts and everything else here as well. So I think some of that might be different across the district. Some of the approaches might be different. The requirements are certainly going to be different with urban areas and rural areas. So I think we need to have a bit of work. I think in your work, there's been a workshop as well on the next item, which I think might be added to that. But anyway, in terms of adding another group, middle-aged old blokes with diabetes could be another middle group, because there's quite a lot of us out there at the moment that don't know what we're meant to be doing. Anyway, so I think we'll leave it at that. But thank you very much for that. And I do hope that we can have some reporting coming back about the sort of tactics you're going to adopt to be able to achieve this?
So just trying to keep us moving, because there's about 4 or 5 behind you. I'll just bring you in a minute. 3 comments. First of all, the strategic plans that Lynn's been talking about are planned to come to committee on the 20th of March, because effectively this is just the high-level strategic plan, and then underneath that is the actual sort of detail to the strategies, and that isn't obvious in the papers, and apologies for that. Second of all, in feedback to Paul, based on what you said, which is very illuminating, 2 things. One is I would encourage you to focus on the biggest wins. You know, housing, for example, to me is a huge, huge win if we can get that right, because, you know, as a core pillar, if we haven't got that right, then it leads to all sorts of insecurity, whether it's in terms of employment or in terms of anything else. And, you know, Marmot and the work that he did 15 years ago, I think is a good indicator of that. But equally, falls, for example, fall within that. And the second one is speed. Sometimes when you've got all these strategies and all these people, nothing ever gets done because, you know, there's too many layers to sort of work through. And, you know, maybe we sacrifice brilliant for good because it takes us a step further forward. Lynn, I know you wanted to come back in.
Yeah, it was just in response to Councillor's question about how will we do it, how will we work with the local the districts and the boroughs. I'm responsible for the Improving Population Health portfolio, which is focused on inequalities and prevention. We've got a portfolio board that we're establishing that's chaired by Tim Clegg and Dave Hayward from the local boroughs. So we've got the partnership in place. I've also been working with Claire McIver. So I know that Claire is looking at bringing the boroughs together to focus on health inequalities. What Claire and I are doing are joining up our plans to ensure that we can maximise the outputs of both the borough plans and our own in health. So we're starting to work a lot more closely than I've ever known before, but that would be the real delivery route for me. And
just, Chair, if I could, just to add to that, of course, that reinforces the Chair's point about housing being the biggest pillar, because that is through the districts and the boroughs and then through the city council. So we absolutely need to get that relationship right. And it's a relationship we probably haven't had before with the NHS properly. What we've also done is to try to help the districts and our primary care networks to understand how they relate to each other as well, so that we're starting that discussion at that level between the sort of the next level down of the NHS at primary care network with the districts and so on, and trying to get that engagement all the way down.
Thank you. Angela.
Thank you very much, Chairman, and thank you for your presentation. It's very interesting, actually. My question, well, I got two, but mainly one was about housing. The first, how are you working closely with Health Watch? Where does Health Watch come into this working with you? Do you incorporate them into your meetings, or do you work with Health Watch at all? And again, housing is one of, as the Chairman's already said, about housing being a biggest problem and to do with health. And I do think that you need to get some of the chief executives round the table, you know, and hammer home the problems that we're having with housing, looking at it from a district level. Thank you.
Thank you, Chair. Just to come back on that. So Health Watch absolutely involved with us. Health Watch are part of the Integrated Care Partnership. They're also part of, I believe, both upper tier places. So I believe they're part of the City Council place and the Staffordshire place as it's developing. So we work very closely with Health Watch on a number of levels. In terms of housing, I think there is that discussion very much about understanding what that relationship is between housing and health, you know, around cold homes, around homes that don't allow people to live a healthy life depending on their family situation, around damp homes, but also around how do we work together around supported living, for instance, when we're looking at developing new housing and so on. How do we do that in a different way that caters for the needs of the population, taking health into account as well as other factors? And I don't think we quite understand all of that agenda jointly yet, and I think that's something that we could really usefully do.
Thank you for that. You know, speaking on a district level, you know, our inbox is normally a lot with people in deprived areas with the housing situations, but thank you for that.
Can I just bring in Baz from Health Watch? Do you want to say anything in?
Yeah, hiya, thank you. Yeah, we have been attending more and more meetings with the ICB and the ICS overall. And part of our deep dives, we are looking at the seldom heard area, and especially now that just hearing about the homelessness. And it's something that we've come across before, and I've come across in my previous roles as well, especially around when it comes to discharges. There's various reasons why they are delayed, and that impacts the entire system. And one of them is housing, and as an example was the homeless community, because under the there's a duty to refer under the Housing Act, and what would happen often is nurses would make those referrals. However, in a practical sense, when somebody would turn up to the council, let's just say, and they didn't get housing because they didn't meet that threshold, and they often are quite poorly because they've just been discharged from hospital, they would end up back on the streets and quite quickly back into hospital again. It's like a vicious cycle. So even though it looks like they've gone out maybe over a 2-week period, but they've come back in several times, and that could add up. So that's some area that we were working in partnership to help overcome jointly.
And I think, Chair, if I could say to that, some of the housing issues could be identified 5 years before the person's admitted to hospital. So, for instance, we talked about falls, the frail elderly. We should be able to go right back and be predictive about those that are going to have problems going forward. What might we do to actually make sure that the housing and the environment that they live in is more suitable and prevents the admissions in the first place, or facilitates the discharge when they are admitted. Second thing is around the homeless and those who we have difficulty discharging. I think between us all, as partners and stakeholders, we get tied up in organisational barriers and crossovers and whose responsibility what bit is and so on. I think there's an awful lot more that we could do together, health, local authorities, voluntary sector and other stakeholders to facilitate that and make that much easier, because you're quite right, otherwise we see the same people coming back around again and so on. So I think we could work together much better on that.
Thank you. And I'm hoping that population health management will give us some of those answers, because that was the promise that we've been told, and we certainly want to hold you accountable on. And please don't forget the role of housing associations, because often they have many thousands of houses, and they have the ability to do some really good things. Janice.
Yeah, thank you, Chair. A few questions, and I'll try and put them in some sense of order, if I can. First of all, I think it's appropriate for me to just acknowledge the breadth of the challenge as what you've highlighted, and also recognise the ambition that's in there. I think that it's also easy when we start looking at economies of scale to bear in mind that there's also diseconomies of scale, and given the size of the task in hand, I recognise that as a comment. Couple of questions. You mentioned, Lynn, about all of the services coming around the table. And that's a premise that I'm very mindful of at the moment, and in terms of our next agenda item as well. So a general question on that with regards to the willingness of engagement generally of those stakeholders. And if I can ask another question at this point as well, Chair. You mentioned about the juxtaposition of the wellbeing strategy. I mentioned previously about the women's health strategy for England. And I think it would be pertinent if I could just ask if that's also being recognised in consideration for those. If I could just hang fire there, and then I've got another question, if I may, Chair. Thank you.
Do you want to go first?
Yeah, I mean, it's a really good question. I've got personal experience of the system working very differently, actually. So I was the lead for the COVID vaccination programme, most people know. The reason we were so successful in Staffordshire is because all of the stakeholders were around the table focusing on the same goal, which was to vaccinate as many people as possible. And that was broader than health and care. We had the fire service fully engaged, taking our vaccines round, picking up our fridges, working as a partner. Since then, I've worked on a number of work areas around asylum seekers, again, the fire service helpers in terms of the logistics, setting up local clinics. So I've seen a real change in this system in terms of partners working together and organisations working together. There's definitely a blurring of lines, and it's really positive. So I don't know if you want to say anything else about that, Paul.
Lost my button. I think just to say yes, and we see increasingly that. So at the moment, as another example, Staffordshire Fire and Rescue have stepped in to provide, just as they did during COVID and some of the vaccinations and supporting us, they've stepped in to provide a full service across Staffordshire, and supporting the one that's already there in Stoke-on-Trent. Another example of how we can work together, and if we just talk to each other, and that gets us round to an extent some of the workforce issues where we need to use our workforce in a different way. And that's where we come to in the 5 Ps. One of those is productivity. It's not about making people work harder and faster. It's not about saying you've got to do twice as much as you do at the moment. It's about thinking laterally about who might do things, what could technology bring to it, how might we do things differently. Look what a difference virtual has made to us in terms of the way that we can work. So there's a lot there. So I think there's lots there. Women's health strategy, absolutely, really, really important to us. It sets out a sort of a long-term vision, if you like. It will take some time for all the elements of that to come together, because it is a strategy, again, that the government have set out. It isn't necessarily a plan yet. We need to take that strategy in as one of those things that we look at and say that's the direction of travel we need to go to. I have a clinical professional leadership team, which will be a multidisciplinary team. We've got a number of GPs as part of that team at the moment, some of whom you will know from the past from CCG days. But part of our next round of recruitment, we will be looking for somebody to lead on the women's health strategy or on women's health. So we will have an individual who will particularly drive that forward and lead that within the team. And I think that's really important. I think we need to do that. Okay.
Janice.
Thank you. That's wonderful to hear. Thank you very much for that. On the engagement side, in fact, can I just say as an aside, it's lovely to see you in person. I've seen lots of pixel versions of various people, so it's lovely to see you. And my mantra, going back to that part, is working smarter, not harder. Yes. That's my premise. In fact, it'll probably be my epitaph, actually. But if I can just mention, it appears that some may be more engaging than others. I don't know if that's the case, but certainly that seems like a benchmark as far as fire and rescue. For others maybe to want to work towards as well. I did pick out a couple of specifics in the presentation, and I'm just mentioning them as an example. So going back to the women's health strategy, it identified certain sections of the community for women who are finding it difficult to access. I just mentioned that as an example, so it's lovely to hear from the commitment that you've just said. And I just use that as an example because you also mentioned about send issues as well in the report that we've seen. At some point, this is actually my biggest mailbox feature, even above potholes, which is saying something. So I think, again, it's looking at, I'm using that, as I say, as an example, to look at any geographical differences. It's, as well as a big job, there's also a big geographical area that's coming through. And for me, I think it's probably looking at some of those, identifying those imbalances, and I'm sure that's one of many that exist within the area that you're covering. I think my colleagues already alluded to the difference between rural and urban as well. Yep. So it's just to give us a bit of a feeling and a flavour, really, of how some of those things are being acknowledged within your piece, within your scope. Thank you.
Okay, thank you.
Do you want to say anything else on that, Paul? Or...
I don't think so. I think, I mean, it will be. We will look at all of those different inequalities. So be it geographic, urban, rural, specific communities, characteristics, all sorts of things. So we will try to cut as much as we can in different ways. Just like you're, working smarter, not harder, mine is always about, it isn't about equal access, it's about equal ability to benefit from that access. And that's why we need to do, I think, what was Michael Marmot's approach, which was proportionate universalism. So we do need to look at the whole community, but we need to target certain parts of it to make sure that they can benefit from the access that they get.
Sorry, thank you. Lynn, you've got your light on. We're with you.
Just very quickly, really, I think that's another difference of this strategy. It's the focus on the fact that people are different, have got different needs. And if I'm absolutely honest, I don't think we've done that collectively in the past, particularly in health. So we know one size doesn't fit all. We know that people want different services, looking for different outcomes and access services in different ways. So that's something that I hope we can really pull out through the strategy so we all start responding to individuals' needs as well as the general population.
Thank you, very helpful. Richard, we're with you.
Thank you. I'm picking up on your 5 key current priorities, and I want to particularly focus on their growing well. I probably should know the answer to this, but I don't know whether you can allude to it in the sense that you're saying over the last 5 years there's been an increase with special educational needs and autism, so forth. To obviously discover a solution, what is the cause to that? Because autism can cross the boundaries. It isn't just necessarily the low-income families. It's very much can be elsewhere. So it's in a sense to get the solutions in terms of to understand it. What is the cause, in a sense, of autism elsewhere in the system? And secondly, in terms of, you made a point about primary care. In a sense, this could be still considered the root of all problems in terms of primary care, and by having access to primary care, and I know that's a different subject, but it does fit into your strategy, because if there's a block somewhere, it's not going to be able to achieve your strategy unless I'm completely thinking otherwise.
If I can start, Chair, on there. So I think two things in terms of looking at these groups. One of the things that we do recognise, so where we've got Grow Well, and we've got 5 to 18 at the moment, Live Well 19 to 64. There's got to be some crossover of those boundaries. They're not fixed. We know that really in a local authority, because my background, obviously local authority before this role, we look very much at 16 to 25 is a group we look at, not 19 to 25. And actually for autism, I think we should be going back to age 14 and looking at that period 14 through to adulthood, because if we don't start planning at 14, we'll get it wrong at 18. So we need to be planning through and working through, because as we all know, the rules change hugely when you move from your sort of 17 and 354 days into your 18th birthday. The rules change very quickly, and that can be a huge shock and difficulty for individuals if we haven't worked through that. So those boundaries are in there. We've got to look flexibly across those different things. Talked about the 7 portfolio groups that we have. One of those is a wide group that looks at mental health, learning disabilities and autism. It also includes substance misuse within it. So it's a big portfolio, but that's where we'll look at autism coming through. So I think that's really where we'll look at that, and we'll pick some of that up. But we've got to work very closely again with local authority colleagues on that, and with the voluntary sector, because rather like housing, it's a complicated area, and there's a danger we end up in debates about funding rather than actually the debate about what's right for the individual, get that right, and then behind it, we sort the funding out. But we sort of bring the funding through to the foreground, don't we, sometimes? And we argue about that rather than about what's necessarily best for the child or the adult.
Richard?
Just on the primary care, I'm happy with the answer to that. Thank you.
Thank you. Charlotte?
So I was previously the Director of Primary Care and Medicine, so I'm very familiar with the issues in primary care, and I've presented here before. I think you're absolutely right. We're not seeing a huge number of GPs joining the profession. In fact, we're seeing people retiring early and leaving the profession. So we need to really rethink how primary care and general practice is delivered. We've employed around 350 additional whole-time equivalent roles that are not GPs. We've got urgent care practitioners, we've got physiotherapists who are working in a primary care network footprint, providing an alternative to a GP who in many cases would be better suited to the individual's needs. So it's about using the wider workforce, nurses for long-term conditions management, for example. We don't want doctors taking bloods, do we? And things like that. So it's about the most appropriate professional for the most appropriate patient and condition. I think there's a lot of waste. There's a lot of bouncing between secondary care and primary care in terms of the workload, and that's something that we're working with secondary care colleagues in Staffordshire about how we improve relationships, how do we make interactions more productive, how do we lessen the number of handoffs. So we're currently developing a primary care strategy, building on all the work we've done with access. The key difference going forward is pharmacy, optometry and dental services are being delegated to the CCG. Oh, that was a slip of the tongue, wasn't it? Sorry, ICB. And so, yeah, sorry. And so we need to be looking at how other primary care contractors can support the agenda and how they can be working together with GPs to build a community of workforce rather than lots of individual practices managing their own individual patients. We need to share the burden, but the access to other services as well as the GP. Certainly the digital agenda's done wonders in terms of access, but lots more to be done.
All habits die hard. Richard?
Thanks for that, Lynn. I mean, it's just obviously getting your message into the system, and for them to realise that they actually should be cooperating and then offering that level of service that can feed back to know how we get things resolved. Thank you very much.
And just the other comment, you mentioned dentistry, Lynn. We have that diarised for possibly the 12th of June 2023. Charlotte, sorry, with you now.
Thank you. There seems to be a fashion at the moment to go with first letters. You've got 5 Ps. You might have added poverty on that. You've got a minister, health minister, going for A, B, C, D. You've got a chancellor going for E's. I just hope we get to the end of the alphabet soon with some action. Because it seems to me that what gets measured gets done. You've got a strategy, which is very broad. How are you going to measure the outcome of your strategy? What baseline do you have? Who will ensure that that is being monitored? Because, you know, we've talked a lot about housing. And in Staffordshire, especially in North Staffordshire, we have some of the coldest, draftiest houses in the country. And poverty is a big issue with food banks, and that definitely has an impact on choices and on health. And so poverty prevention should have been one of your Ps. So how are you going to be measuring the outcome of this strategy? Because it seems to me that we've seen loads of these strategies going back over 30 years. Why is this one going to be different? Is this one going to be measured, or is it just going to be left blaming one of the partners for not delivering on something? For instance, would you take the number of beds at acute hospitals being blocked by people who are requiring social care, people who are ready for discharge but can't be discharged because there is no social care package or social care or nursing home place? Will you be measuring where we are now and where we will be hopefully in a year's time? Because I've heard from a minister this morning that they're talking about moving to a target of 76% of A&E patients being seen within the 4 hours, not the 95% that we've been working on for the last, previously to this last 10 years. So how are you going to make sure that you are measuring the key outcomes, and what areas are you going to be measuring, and who's going to be responsible for ensuring that that measurement is used to hold different partners to account?
That's a big question, Chair. Claire, could we go back up to slide 8, please? So just in answer to that, I see that being 3 levels. So I see strategy, plan and outcomes. And those are the 3 things that we need to do. I think, Chair, at the beginning you talked about the outcomes. Going back to sort of mantras again, I've got a military background, and I know military commanders always push and say any strategy and any plan is only as good as its implementation. So we can have as many strategies we like and as many plans, but if we don't implement it, we don't demonstrate we've implemented, then actually they were a waste of time. And I think that's really what you're alluding to, is how will we measure that it's making a difference? I heard the Minister as well this morning talking about the 75% target and doing things very differently. And I think it's for us to say, how do we want to do it in Staffordshire and Stoke-on-Trent? What is it we want to do? I go back to those 5 top areas that we're looking at. And we want to do those. I see the 4 things that will change dramatically for us at that very, very top level is the crowded emergency department, the long wait for elective care, primary care and social care. To me, those are the 4 tyres on the car, and they all need to be at the right pressure. They all need to have the right amount of tread on them. We need to look after them all. If we only do one, the others will fail. So we need to be able to do all 4 of those and drive them forward. Jointly, we need to agree what those outcomes are. What do we want to see for the residents of Staffordshire and Stoke-on-Trent? How will we hold ourselves to account in the ICP? So it is a joint partnership. How will we hold ourselves to account? The ICB's role in that, I see as being the organisation that will pull together, on behalf of the Integrated Care Partnership, most of that information and most of those outcomes, working with local authority colleagues, because if we want housing data, we want data around social care, we need to work with our partners. We need a collective outcome framework that we can work to in Stoke-on-Trent and Staffordshire. And that will be the 3rd part of what we do, strategy, plan, outcomes.
Who is going to be responsible for measuring these outcomes? It's fine for you to come here with a plan. You know, we've had so many plans, and we haven't got years and years and years to develop it. Now, you know, we've talked about housing. Well, I haven't seen any significant programme to improve housing insulation, for instance, or to use greener technologies to ensure that our houses are fit to live in. And if you're only going to be measuring the ones you mentioned just there, then it's not going to be much of a strategy, and it's not going to be much of a partnership. So who is going to be responsible? Presumably you've got it, as you've got the strategy, you must know who is going to be responsible for making sure that that strategy is delivered in a way that we as the public can understand.
Okay. If I just come back very briefly on that, Chair, because as I think I said in response to an earlier question, it's a complicated, crowded playing field with individual organisational responsibilities. But overall, the statutory organisation that has the responsibility for delivering this strategy is the Integrated Care Partnership, supported by the Integrated Care Board. But the Integrated Care Partnership is a statutory body. It's not an organisation, sorry. It's a statutory body which is charged with developing this strategy and then overseeing its implementation. But the ICB will provide an awful lot of the powerhouse and the work behind that to provide the information.
Sorry, Charlotte, can I just bring Lynn in, because I think she wants...
Yeah, just in terms of the how will we know bit, ultimately the aim of the strategy is to improve the healthy life expectancy. So that's the overarching aim, but clearly that's going to take many, many years. So what we're developing is a number of short and medium-term objectives that will have metrics that wrapped around them across the life course. So, for example, for the living well, clearly that's an age where we'd be seeing increasing long-term conditions. So CVD, for example, may be one of those objectives that we're measuring. I think what we need to do as a system is develop one version of the truth. We need a single reporting mechanism and data set to be able to say, well, how will we know? No, that's not going to happen overnight, but we are having conversations with local authorities around shared JSNA data sets that we can tap into. We're looking at developing a single approach to analytics across the system. So we do need a single version of the truth, and the key touch point for monitoring that will be the ICP, like Paul says.
Thank you. Charlotte.
Just wondered if we'd have it by the end of March. I mean, I think the plan is for the end of March. So will we have those reporting systems sketched out at the end of March or not?
I think, as I said before, it's a 3-stage process. I think it's a recognition nationally. It is a very rapid process. So I think when we come back in, I think the end of March, Chair, we're coming back with what will be... It will be a plan derived from the strategy. It will need further development because in order to have that discussion with wider partners, etc., there will be an ongoing discussion. And as part of that, my understanding is there will be an early description of what the outcomes framework might look like, so that you as a committee will be able to see the strategy developing, the plan delivering underneath that, and then the outcome measures, the outcome framework under that. So hopefully by the end of March, you'll be able to see how that is developing.
Thank you. That's really useful, because the other bit is, if it isn't there, that's something that we can make as a recommendation that needs to be there, so that we all know that we're on the same journey doing the same things. Can I bring in Phil Hewitt?
Thank you, Mr. Chairman. To be fair, Charlotte Atkins sort of stole my questions, so thank you, Charlotte, for that. But I'd like to make a point rather than a question, if I'm allowed to, Mr. Chairman. Firstly, I think it's great that we're looking at this. We're looking at this in some detail, so I congratulate that we are looking at the strategy. We are looking at outcomes, because outcomes are everything. I used to work for a major drugs company, and the only real result was the outcome for that, whether it was a success or a failure. But if in my most simplistic manner, Chairman, if I can say this, the outcomes really, firstly, we have to measure them, and that's absolutely right to do that. But the outcomes really are, in 12 months' time, whether the general public, whether our residents can see a difference. So whether, you know, the thought of getting a GP where I live, well, you know, it's just impossible. Unless you're prepared to sort of just keep eating repeat at 8 o'clock in the morning. Well, I'm not alone in that chamber of having that. The outcome of seeing on the news, I haven't experienced it, and God willing I won't, there are ambulances lined up 10 and 12 deep, or that somebody has a very serious medical emergency and it's 3 and 4 hours before they get there, rather than, you know, 6 to 10 minutes, which is what used to happen, you know, in the not distant past. So the reality is, Mr. Chairman, I want to see the metrics. I want to see the metric as to how we're improving, and if this strategy is or isn't working. But the reality is, and the real core of what we do here, is that residents see it. That we are not presented with metrics that say this is improving. That actually residents, as Janice said, stop emailing us and stop sending us, and we stop seeing, it's not the lead on the news that you can't get to see a GP. And I accept it's always going to be quite challenging. In my lifetime, it's never been the easiest to see a GP in the last 10 years. It's just become notably worse. So it's more a comment, really. I don't require an answer. What I want to see is residents notice the difference, not necessarily in this chamber, Mr. Chairman.
You always tell me off when you say that you don't require an answer, and then I don't pass it over to our guests to respond. So I am going to pass it over to our guests, because I have a feeling that they may be in violent agreement with you.
Thank you, Mr. Chairman. Brilliant as always.
Yep. Absolutely. And we will have failed if all we do is change a few performance indicators and make no difference to the experience of our residents. And one of the ambitions of the ICS and the ICB is to improve outcomes in terms of experience and access and so on. So it's looking at that wider experience. So if we improve, I don't know, ambulance response times by 10 minutes, but actually our residents are saying it's made no difference at all, we still get an appalling service, then we'll have failed. And I think what we'd like to do is to turn the dial from where it feels like we are now, where everybody is saying, I'm getting a poor experience. Everybody's talking about the long waits for ambulances. Everybody seems to be talking about difficulty seeing primary care. We need to change that to be the exception. And that's the perception that we need back, is that these are exceptions when you get an email or a letter saying, I can't do this. It's an exception, not something that is more common.
Mr. Chairman, can I come back on that, please? Firstly, thank you for overriding me and getting Paul to answer the question. It was Paul, wasn't it? Yeah. Because I think we get that. I think we're on the same page. We really want to see tangible, proper improvements. Thank you, Mr. Chairman.
Thanks. Mike.
Thank you, Chairman. If we accept that early intervention and prevention are key factors in the strategy that you have, are we doing enough at that early stage through education, through the school works that we do, to actually bring that forward? Because obviously, if we can get people engaged in it at an earlier stage, then obviously through life, we'll reduce the number of people that we do need to go into care at a later date. So it's really around what are we doing, or what more could we do locally within our education piece in the schools?
The easy answer, I think, to the first part of your question is no. I don't think we are doing enough. We need to focus, and this is where, again, Lynn talked about what's our long-term aim, what will we achieve in the medium term, what can we do in the short term. And for me, I always break prevention down into primary, secondary and tertiary prevention. So the primary prevention that you're talking about is largely at schools. It's tackling issues around childhood obesity before they start. It's about healthy eating. It's about lifestyle. It's about all sorts of things that we do that primary prevention. I think, Councillor, you mentioned diabetes before in middle-aged men. In my case, high blood pressure. What can we do earlier on to stop that happening? But when it does happen, what is it that we're doing at that secondary prevention level? So I have high blood pressure, won't get rid of that now. So how do we prevent me having a stroke or so on? So that's the secondary prevention that comes in. But going back, there's a huge amount more we could do. Michael Marmot, we've quoted him a lot today, bless him. Michael Marmot would say, if you can only do one thing, then it's the best start in life is what you should do. Focus on the best start of life, start early, make sure that our young children have the best start in life in terms of the health care that they get, the education they get and the support they get, but also in how they set up the rest of their lives, because you learn those habits really early, don't you? So I think the answer will always be, no, we're not doing enough, we could do more. And that's part of what we need to tackle in this, is how do we get back and do that? Again, as partners, the NHS could do more, I think, than we do at the moment, working with local authorities, voluntary sector, education, and everybody else and so on. But it's what could we do as the NHS? How could we help to do things differently and get further upstream?
Mike? No? Okay. Angela.
Thank you very much, Chairman. And Mike actually has mentioned something that I was just going to bring in about early intervention. And my main my main question really is, you mentioned just earlier on, Paul, about autism, 14 to 17. What are we doing early intervention with children in mental health? You know, where are we looking at with that? Because that is a major, major issue. If we don't catch these children early enough and give them the help that they need, and I'm talking about 2, 3, 4, 5-year-olds now. I'm not talking about 14 to 17-year-olds that you mentioned earlier. We've got to step in long before then and help these children so we don't have the outcomes when they get into the teenage years of having the problems, which costs an awful lot of money to try and help these children. So my question is really, what are we doing about mental health in early intervention, and what can we do? Thank you.
So I always love you, Anne, because you're so far ahead of us. You're actually probably 2 weeks ahead of us, because this mental health strategy, both young people and the main mental health strategy, is coming to committee in 2 weeks' time. So unless Paul specifically wanted to respond.
I was going to say the same thing, Chair, that we're looking at that in a couple of weeks' time, but also just again, we've got that one of the 7 portfolios is around mental health, LD, autism, substance misuse, and it is very much cradle to grave in terms of that. So it is looking across the life course and very much looking in everything we do at what would we do to prevent things happening, either primary or secondary, because it might be with some of those children, if they do have a diagnosis of autism at an early age, there is no magic cure for that. It's how we then manage that and how we manage. So that would be a sort of secondary prevention. I think probably, as I think you'll see when the strategy comes, the mental health portfolio is probably the most advanced of all our portfolios. So I think you'll see when that comes, you will see how we are trying in everything we do to get ahead of things. And what I want all the portfolios to do, and Lynn and I have talked about this, their 3 questions should be, on any issue, what could we have done to prevent it? Or could we have done more? How might we tackle the health inequalities that are embedded in it? And then to come back to the Chair's point before, what does population health management tell us about those individuals and how we might work with them?
Just mentioned, Chair, I do apologise for that, about bringing that in, but it's just that Paul mentioned about autism and 14 to 17-year-olds. That's why I asked the question.
No, I was being very fair, Anne. I knew you were ahead of the game. Can I just, in closing this session off, just make one point and then try and see if we can answer the questions you sort of put on the screen. My point, first of all, is whilst I was on holiday a while back, I read a book by Atul Gawande called Being Mortal, which looks at particularly end of life. But I think it makes a really good point, which is about quality of life. Let's make sure that whatever we do, we extend the quality of people's lives, not just extend people's lives. But it also, and this is the point I really wanted to make, it also talks about having brave conversations with residents. And I wonder whether you're being very, whether within the strategy, you are very clear in terms of what you expect from residents. Because I think if you don't create that marriage, you don't create that bond of we will do this, but this is what we expect from you, I think, unfortunately, then we fall into the trap that has been laid for many, many decades, which is we can do what we want today and we're not going to worry about the consequences tomorrow. And so I would just encourage you to look at that. So just bringing to a close this session, if I can, you raised a number of questions with us, which we haven't really picked up. And I wondered, could we just go back to that slide, please? And I wondered whether the right thing for committee to do was just to reflect on those. Maybe we'll create a straw man and then a separate discussion, because given the importance of the strategy, if we're on the wrong strategy and we want to go to, let's pick somewhere, we want to go to Stoke-on-Trent and we start by going south to London, then frankly we're never going to get to the right place. So I wonder, committee, whether it would be worth creating a straw man and then just doing a virtual session where we can provide some feedback and some answers. Committee, are you going to nod? Are you going to say yes? Yeah, okay. We'll do that. What sort of timescale do you want some feedback?
4 weeks. Yeah, it's good. Would 4 weeks be enough time, Councillor?
More than plenty. Time expands out to the amount of time available, in my experience. Okay, so on that basis, first of all, thank you, Lynn, and thank you, Paul, for what you've shared. I thought what you brought to today's discussion was so much more than the papers, so thank you for that. I think there is a lot of work in progress, and I think we all want the same outcomes, which is improvement in quality of health, and I look forward to bringing this back again in March to see some more of the detail behind that. Okay. Please stay, please go, whatever you feel. We're going to move on to item number 5, which is inpatient mental health services, previously provided by the George Bryan Centre. Anyone who's read the papers in detail will know that this isn't a review of the business case. We've already done that piece. Instead, this is a review of the outcomes from the recent NHS England assessments and equally a what are the next stages. So if we can focus in on that, I'd be grateful. I'm going to hand over to Paul again.
Thank you, Chair. You'll be absolutely fed up with my voice in a minute, so I'm only going to talk for about a minute and hand over to Helen. So it was just to say that, as you've said, Chair, we've got a paper for you which just sets out the background and This, as you know, has gone on over a number of years, so the background set out for you there. We then set out the current position for you, and I guess the key paragraph in there is paragraph 18, which is that the pre-consultation business case, the consultation document, presented to the ICB board on the 19th of January this year, and the board approved the recommendations for the pre-consultation business case, the communication plan, and also the consultation documentation. And what Helen is going to do today is just to outline to you what that communication and engagement plan is, and how we're looking to take that forward. So I'm going to keep quiet now, if that's all right.
Thank you. So following on from our presentation that we gave to you last August, and thank you for the scrutiny that you gave us from the pre-consultation business case that we presented at that time, and the subsequent meeting that we came to in October to answer the questions that you'd formulated from that meeting. We have held both an informal and formal meeting with NHS England, where we presented the pre-consultation business case and associated documents. We have now received the formal feedback from NHS England, which outlines that we have met the tests of change that are set out within their guidance, and the best practice checks, which was then the stage which meant that we could present the documents to the ICB board, as Paul has just outlined. So within those recommendations, the board also agreed to undertake a 6-week public consultation, and the attachment that you have with your paper today outlines the steps that we would take within that 6-week consultation. So we are looking to start the consultation on or around the 9th of February for 6 weeks, with a midpoint review where we will be able to assess the reach of stakeholders through that consultation process. We have outlined a number of mechanisms to engage with the public and key stakeholders through that time, and making sure that we've got a range of online events, online survey, but also paper survey, or if respondents want to talk through the questions and provide their response, we have the opportunity to do that over the telephone. We will have a number of drop-in events across the geographical area under concern, and we will also be attending a range of voluntary sector and stakeholder meetings where we'll be able to provide information and be able to support people to provide feedback. The responses from the consultation will be presented back to the ICB through a report of findings, which we will then bring back to the committee here for you to be able to take into consideration before making a formal decision as an ICB board on the outcomes of that report of findings. Thank you.
Thank you, Helen. I'm not seeing anyone indicate. Oh, yes, I am, Janice. Sorry, I need to. I'm going there tomorrow.
Thank you. A number of questions. I appreciate this is on the consultation part, but if I can also just explore some of the content, just for my own satisfaction, really, as to the information that has been shared. The business case so far and the decision-making business case, where have those been shared with regards to the content of the information? And the reason that I ask that is that, and Chair, you might need to give me a little bit of liberty here, is the element of the travel component. And it may well be that there's some information that is shared that I am not aware of. So that would be my first question, if I may.
Okay, so the business case and associated documents were shared with the committee, and I think we had a good couple of hours scrutiny in August, which was really helpful in terms of feedback in how we amended some of the elements within the business case before it was submitted to NHS England. We did provide formal response back, and we came to a meeting in October in terms of that, and we did provide, after the October meeting, the draft travel policy that MPFT have developed. We asked for responses back, but we have also, within the questionnaire that we have developed for the consultation, is we have included travel questions within there for further feedback from patients, public, family members in terms of that. We have also, within the business case, outlined the mechanisms that MPFT also undertake to support family members and patients to connect with their loved ones when they're within the hospital environment. So either through flexible visiting, digital visiting, etc. So, and each, as stated at previous meetings, each individual is looked at through the requirements of both themselves and their family's needs.
Just on that, I think it was the July meeting of this committee, but there were 608 pages. So if you don't remember them, I certainly do. The other location for documents is the ICB board meeting. I think it was on the 19th of January, and it was certainly discussed there. And there's a whole rook of papers, and you can watch back the stuff there. Sorry, with you.
Thank you, Chair. Now, in that case, then that's clarified the part that I certainly did read all of those pages. And so I made some responses to there, and I just wanted to make sure that I hadn't missed those. And one of them was about engagement, which we were talking about in the previous session. I think I'd referred at the time about how do we have a dialogue with other services, such as the police. And I was acutely aware at the time, but just to quote some examples, that Wiltshire Police had recognised a jump of 248% in their reports that were being made for mental health call-outs. And that I think there was Lancashire Constabulary reported a 243% one. So for me, it's looking at, are we trying to make improvements in one area, which is a positive one, but is having a negative impact in another one, and how we are linking with those to make sure that that isn't the case in this specific episode.
I'm going to really try and keep us on the agenda item, which is the communication plan, because otherwise we'll talk about everything in mental health, and then we'll talk about every facility in Staffordshire. But Helen does want to come in. So, Helen.
I just want to say that as part of the process that we've undertaken for ICB governance and through NHS England, we have undertaken full quality and equality impact assessments that have been signed off, and the equality impact assessment was reviewed again in November to make sure that it was valid and up to date, and those will be reviewed in light of the feedback from the consultation as well.
Maybe the other thing which is worth considering is that mental health strategy is coming to the committee in 2 weeks' time, and you might just want to reassure yourself or assure yourself that what is being proposed here for this facility actually meets and is in line with both the Staffordshire policy as well as the NHS England policy. Not that I want to lead you in a direction.
Yeah, I'm sure that wouldn't happen anyway, Chair, but thank you for the kindness. I wasn't satisfied at the last meeting, and I think that those assurances are still something that I would need to have. With regards to focusing on the survey side, I wanted to be equally clear that all of the information was going out, which is what prompted my initial question as to where it's being shared, so that informed responses can be received from the survey. So that was why I did say I may need a little liberty, because I think that it is important that all of the information is being shared in a manner in which, whether it's any of the stakeholders, whether it's residents, whether it's patients, whether it's the staff, whether it's those ancillary services that may be impacted, are being able to make an informed response to the survey.
Helen, with you.
Okay, so all the resources will be available through the ICB website, with links through to the MPFT website as well, so people can access that way. On all the documentation that we will be circulating in terms of the consultation plan and questionnaire, they will be available in different languages, easy read format. There's that opportunity for people to have that one-to-one feedback if they want to, so that then if they're unable to answer either via online or in a written format. So there's a range of ways that people can access the information. It's there, it's available, but we have a range of different ways for people to be able to feedback as well.
Okay, and if there's some information that maybe is missing, is there a mechanism for people to be able to request that information specifically? Okay.
Yes, it'll all be within the there will be key contact details in terms of how to get in touch with the team to ask for any further information.
Just one last point. So obviously from my perspective as a county councillor, as a district councillor, I would be very keen to share that, especially with the residents that have written into me personally, who live within that particular constituency. And I would be more than happy to pass over any links to the surveys to make sure that you get a full response as possible. Thank you.
I'm just looking around the room. I've got a couple of questions, if I may, please. First of all, could you just explain in implication terms the recommendations being put forward to committee, particularly item C, or exclusively item C? We talk about a substantial change to services. I understand that's our decision and not the NHS's decision, but could you just explain that through? And then my other two questions are these responses all going to be, the responses to the consultation, are they going to be published somewhere? And second of all, on the consultation itself, are you making a set of commitments in terms of, if you write to us with a question, we'll get back to you within 7 days, and those sorts of things? I.e., are there some clear engagement commitments that you're making as part of this?
So in terms of the substantial service change, within the document we've outlined the numbers of people that have been, that suffer with mental health problems across Staffordshire, and within the pre-consultation business case we have looked at that activity in terms of the numbers of people that are likely to be affected who will require an inpatient stay at St George's Hospital in Stafford. So we believe that's approximately 5 patients per month that would be impacted, and be looking to, obviously the impact is upon the carers as well in terms of being able to support them. So it's whether you see that as a substantial service change in terms of those numbers that are outlined within the paper. If you deem it to be substantial service change, then the Overview and Scrutiny Committee would have the opportunity to feed back once the report of findings has been developed, so that you can have your, you can provide your feedback to us, but we would not be able to make a decision as an ICB until we have received your formal feedback. So there would be a number of meetings that we would need to take after the consultation is closed and that we've received that report of findings. In terms of publishing, the report of findings will be published, and we will bring that back to the Overview and Scrutiny Committee anyway as part of our ongoing conversation with yourselves, as well as being taken to the ICB board and incorporated into a decision-making business case at that point in time. So we would be looking at the end of the summer before that decision-making business case is put forward to the board. And in terms of responses, the responses will be collated into the report of findings. I don't think we will write back to each individual, but we will look at in terms of those themes and those key elements. If somebody comes forward with an alternative proposal that we've not taken into consideration, we will take that into account. If any of those proposals come in before the midpoint review, we would then look at whether we need to extend the consultation period or whether we need to change the way that we're approaching the public to be able to manage that. Paul?
Thank you. Can I bring in Tracy?
Thank you. I think Helen, and apologies, Chair, for not being with you in the room today and not being mobile from home. So I think Helen's covered most of the points, and just picking up on the previous councillors, we want to be transparent in this process. We have to be transparent in this process. So we will be reviewing how we receive the communications. If we feel that people are not responding, if we haven't got it right, then there will be reviews all the way through the process. I think Helen has picked that up. We're having a midpoint review as well to ensure we are checking ourselves that we are doing this absolutely as we need to do it. And the key thing is, if there are alternative proposals that are brought forward, we are duty bound to look at them and give them due regard and consideration, which we obviously will do.
Thank you, that's really useful. Anyone else want to ask any further questions on this? So we're being asked to look at a number of recommendations, obviously to receive the update in terms of the work programme, which I think is in front of us. Second of all, to look at improvements or changes, recommendations to the communication and involvement plan. I think that we've discussed that in detail. And finally, whether this constitutes a substantial change in service, and I think Helen's indicating the number of people impacted is 5 per month. So do we have any points on this last point? No, okay, so are we deeming this a substantial change to service? Don't think I'm getting anyone saying that it is. So on that basis, I think we can move to a recommendation of committee. Are we happy with what's been proposed in front of us this morning? Thank you. Obviously, other stakeholders can come with a different perspective. I'm thinking very specifically the 2 local district borough councils affected, and obviously individual members of this committee can do the same. I should, for transparency purposes, also just mention I have a number of questions from one of the councillors who isn't with us this morning, which we will submit to Helen, and Helen's going to write back with the responses to that. It's not relevant to the communication strategy, which is why we haven't raised it as part of the communication strategy in front of us. So, on that basis, I'm going to thank you, Helen, and Paul for the update this morning, and I'm going to move on to item number 6, developing integrated care hubs in the context of changes to NHS capital arrangements. I should just pay tribute to the Vice Chair, Richard Cox, who's done significant amounts of work on this through his working group. Do you want to say anything, Richard, or shall we pass to Claire?
If we can go to Claire, and then I can add comments.
So, Claire, we're with you.
Thank you, Chair, and good morning, committee. So I'm Claire Trenchard, for those of you that haven't met me before. I'm the Associate Director of Communications for MPFT, and joining me today on the virtual screen is Richard Morris, who's the Director of Corporate Governance and Communications for MPFT as well. So good morning. So all I wanted to do this morning, Chair, was just say a few words by introduction, and then actually I was also going to do what you just done and invite Councillor Cox to maybe make some comments, and also other members that have been part of the working group. So a year ago, I came to the committee to update you all on the MPFT's progress in delivering the decision-making business case of the CCGs at the time to implement the 4 integrated care hubs across North Staffordshire and Stoke-on-Trent. And I came with 2 asks. One was, how can you support us to ensure that we're not going to each committee that has a hub in their locality, and also to give thought to how you can support us on this journey, which will be many years. So you agreed to set up a working group, and since that working group has been established, we've done 3 things. MPFT has organised a site visit of each of the 4 locations contained within the decision-making business case that will be having a hub, and to those site visits we also invited the City Council, your counterparts in the Overview and Scrutiny Committee of the City Council. We then met to have our inaugural meeting, And at that, the working group received a presentation in two parts. The first part was delivered from our frontline clinical colleagues around the model for integrated care, and it included some of the pilots that we are progressing, which is included in the report in front of you today. And then the second part was the changes that have occurred within NHS finance regime since the decision-making business case was signed off by the committee in common by the CCGs. And then earlier this year, we met and I shared with the committee in a sort of informal session the proposed process and criteria that MPFT and indeed the system will deploy to determine the order in which the integrated care hubs will progress. That is part of a wider stakeholder engagement process. MPFT is very committed to co-production, and this is going to be an iterative process. And the working group of this committee was the first step in that process. And the presentation included in the paper also contains the feedback from that working group to that initial presentation of the process and criteria. So, Chair, in essence, that's all I was going to say. And then my intention was to invite the chair of the working group and other members to make comment on the process to date.
So before I bring in Charlotte, Richard, do you want to say anything?
Yes, if you may. Thank you, Chairman. So, in terms of the for members of the committee, everything really is in the paper there. But I just want to add that we did the site visits were of use to try and determine how we, that they're going to be suitable. There are going to be challenges ahead at those sites for sure, and in fact I might have to say the one site has got to be built from scratch because it's an open rubble field. And the challenges, for example, at Leek, it's a listed building and they've got constraints, but I'm sure there's a will there because the concerns that we felt from Leek in terms of the being referred to after 4 o'clock, I think it was, Charlotte will be able to confirm, it was 4 o'clock, that you'd be transferred to Hayward. And then if you look at the Hayward site, there's part of it has still got to be, there's a situation where it's partly closed because of concrete situations. So there's elements that have got to be dealt with there and Bradwell. So we learnt a lot from those site visits to get that vision of how those units would be. I think it was probably fair to say that there is certainly, again, if we were looking at Staffordshire Moorlands, with the transport issue is going to be something that needs to be addressed and overcome, but I think we can recognise that that's the case. And then I think regards, finally, which is probably fundamental, is that if we look at the funding process that's involved, the fear would be that one of the hubs drops off and that's not to be in our view. We want to be sure that this is all occurring. So that's really in summary, other than what's obviously in the papers, if that's helpful to members.
Thank you, Richard, and thank you for the work you've done to get us to this point. Charlotte.
There's no funding in the plan for these hubs. And now that the Midlands Partnership has to bid for funding, will those bids have to be for each hub, or would the bid be for all the hubs? And what is your estimate of how much delay the requirement now to bid for capital funding will create for the implementation of these hubs, which are already going to be 2 to 3 years away? So what's the time span you're now working on, and which criteria are going to be used to establish which hub gets developed first?
Claire, I think we're with you.
Yes, thank you, Chair. Thanks, Councillor Atkins. The purpose of creating and developing one strategic outline case for each of the 4 hubs enables us flexibility to either, if the intention is to submit one at a time through the NHS bidding process, but working up the documentation will enable us opportunistically to apply for other pots of money. So, for instance, Councillor Cox references the concrete issue at the Hayward. That is funding that the government made available to address that particular issue, which we were able to take advantage of because we'd done the necessary paperwork. So the intention is to have one set of documents for each of the hubs that will enable us to bid for money opportunistically. So there is potential that we would progress more than one at a time. The question around delay, the first working group, we presented the timetable. By May of this year, we were anticipating to be one step ahead of where we are. And that has built in a significant delay. And we will know better in June of this year the full impact of that delay, but we are around 6 months, I think, behind where we should have been at this particular time. And then the third point, Councillor Atkins, around criteria, that is what we are working through at this point in time. MPFT takes a very, we're very proud of our history of co-production, so we want to get the criteria, we want input into the criteria at this early stage before we apply it. And the next key milestone for that is the end of May, June of this year, where we will have what is called a strategic outline case for each of the 4 hubs, and that will contain a significant amount of information that will enable us to apply the criteria that we've developed to determine the phasing of the hubs. We're still committed to delivering all 4. It's just the order that we are looking at this stage.
Can I just clarify? When you say you're going to be developing paperwork which will then apply to all, well, the 3 of them, and then, of course, the 4th, which doesn't exist in any building form at the moment, one assumes that they will be tailored to each individual hub, because having visited all of them, or all the ones that could be seen, then they're all very different and have very different challenges. So presumably the paperwork will be different for each one, because obviously, you know, as has already been mentioned, the Moorlands one has significant transport issues. Obviously, Hayward has already got a bit of it not operational, and Longton doesn't exist. So, you know, clearly there are very different approaches, and of course the populations are very different as well.
That's correct. And so I can confirm that each of the, we call them strategic outline cases, which is the first step in a 3-step process to get the funding secured for each site. And they currently are also taking into account the demand for each of the services in those particular locations, and therefore the size of the building. So at the moment, there is a range of sizes for each of the building, and each of the strategic outline cases will present various options for each particular site. So they will contain very similar headings, and they'll look very similar, but the content will be tailored to each site. Yes. And then the criteria in terms of the travel and the demographics of the location of the particular area will be common across all 4 sites, and then applied to the information within each strategic outline case.
Thank you. Finished, Charlotte? Keith.
Thank you, Chair. Firstly, can I say, disappointed I couldn't be part of the workshop, so I know that you've done a lot of work there, Richard, and your other people that went round with you and everything else, so I appreciate that. So I may be covering things that have already been covered, so apologies for that. I wasn't, as I say, I wasn't involved in the workshops, and I come from the north myself, as they say in the business. Obviously, around Leek Moorlands Hospital and everything else, I'm concerned that we don't end up with the services that we need. That's my main concern at the moment for the population, and I'm sure that's been expressed already. So I just wondered, in terms of the services overall, we do have a fairly major health centre in Biddulph as well, and other things like that. And what my concern is that we may pass up opportunities to be able to allow people to stay in their own local areas. Travelling from Biddulph to Leek, for example, is extremely difficult. And particularly, I noticed that the long-term conditions, you haven't really worked up on that yet at the moment. But if you're having to do a lot of, something, visiting on a regular basis, for example, self-diabetes every 2 or 3 months, and you're having to travel from Biddulph to Leek and everything else, I can see people being quite severely put off for that. And I just wondered whether or not you're looking at the wider environment across the moorlands, as well as Leek Hospital, to be able to try and integrate Leek and other services we have, or would people in Biddulph be expected to then go towards the Bradwell or Haywood or whatever area instead of coming to Leek, which would then support the Leek case study? So I'm slightly concerned about how people and where they would go and how the demographics might work and everything else like that. And then if I can just bear with me on this one, as they say in the business. Business plan.
Sorry, I don't want to rerun what's been done in the working groups, because the whole purpose of having a working group was for them to do the work and just us to skate across the surface.
Well, I understand that. I'd like to know whether that has been looked at, but anyway, I'm sure it probably has done. I just want to.
Well, maybe you need to ask your colleagues on the district council who nominated the people on the working group.
Right. Okay. Well, anyway, I'm asking it here as a member of this committee. But anyway, go on to the business plans. In terms of trying to put business plans and business cases together in relation to how you're going to prioritise the 4 of these ones, are you planning to help work with the district councils or even the county council in relation to putting those business plans together at this stage? Or are we just going to be sort of in the wing somewhere and you just report back to them at a later stage? In terms of the process. Is there going to be any active involvement at all in putting those cases together outside the working group, or is the working group going to continue putting some information into that process?
Chair, I'm really happy to answer that question. So it's called a strategic outline case, and it's very much a technical document. And I'm really happy to circulate to this committee the presentation that went to the first meeting of the working group. I've only shared the one for the second meeting. And in that, it explains what is required by NHS England for each of the cases in the 3-step process. And at this stage, it's very much a technical document. How much will it cost to build, how much square metres, and based on the demand and capacity, how many square metres will we need in its most simplest sense. So it's very much a technical document. And then we are working through the working group and other stakeholders around the criteria that we will apply, as I say, to the sequencing of it. So the strategic outline cases are a technical document that will be developed internally by MPFT, the intention is to share those with the working group. Hopefully in June. We are on schedule for those to be complete by the end of May.
No, I think you've had the offer for the papers to be shared with you. I think that's what I heard Claire say. She's just nodding. Richard, do you just want to pick up the piece in terms of Keith's question in terms of the robustness of the work of the working group, please?
Yeah, I mean, the working group are working together with the district and borough councils in question in the Stoke City Council. We're obviously, in terms of looking at, the sites in question and taking those forward to how they would best work for their particular areas. With regards to, obviously, that robustness, I think there was clear that the members have concerns for each of their area, but obviously has to be addressed. It would be then collective to make it the right decision. So in terms of, I think the questions that we were asking were to formulate that, Keith. Without doubt, I think they were covered, if that's the case. But as I said, there should be feedback within your own district and borough from it, because obviously it was Newcastle and Moorlands and the City of Stoke.
Thank you. Keith, do you want to come back on?
Only timescale, really, in terms of if we are going to try and do something through the districts, separately, you know, in terms of additionality, whether or not we've got time to do it. Or do we have to wait for the business plan to be put forward and then make comment, which is the way that you would see it happening?
Well, I think Claire is indicating that she'll come back with a business case either to the working group, if that's appropriate, or to this group. I think it depends on what's in there to be able to answer that, and I think that's probably Richard's call as the chair of that group. But obviously, whatever happens, there'll be a summary into this group. It's the whole purpose of the working group, so that they can... Do we have any other questions on this? I'm going to just, in which case, I'm just going to take a bit of license. A couple of things from my side. One is I don't think we, and I don't think Claire's proposing this, should get involved in prioritisation of services, you know, one geography against another geography, because frankly we want all of the money to come into Staffordshire and Stoke-on-Trent, because actually it should be a good news story. So I think we should stick out to that, and I don't think that's what was being proposed here in any case. But I do think we probably have a role in that what was meant to be a good news story because there was additional investment coming into Staffordshire because it's sitting in MPFT's bank account. It's clearly disappointing that they can't go and spend the money that's sitting in their bank account aligned to these projects, which means that effectively our residents are being disadvantaged by the decision by NHS England. And there's also risk that the projects won't be delivered as fast because it sounds like they'll be in some sort of sequence, not wanting to put together what that sequence is, but stick with me. So my question is, what do we want to do about that? Because I would have thought we were a bit disappointed those projects aren't coming forward as fast through no fault of MPFT or the ICSs. And so I wonder whether you would like to take a strategy which talks about writing to NHS England to express our disappointment, and that actually suggests to them that any ongoing projects should be outside of NHS England's capital funding bid process, which would then potentially allow these projects to carry on as they were previously. We can sit and do nothing, or we can try and at least make our voice heard, because this is unfortunately disadvantaging some of our residents through no fault. And I suggest that we then also might want to copy in the local MPs. Charlotte.
I think we all might also want to copy in Patricia Hewitt, who's conducting an inquiry into the ICS strategy, which I think maybe her initial interim proposals have already possibly seen the light of day in December. But she's not due to, I think, find a report until the end of March. But it seems to me that if you have an ICS strategy which is based on things rolling forward, including capital spending, then suddenly for the department to say you've got to bid for that capital funding, but it doesn't, well, it's not included in the plan, seems to me to upend the whole strategy. Because inevitably, if you're going to do things differently, you need different buildings which are more suited to collaborative working. And clearly, from our visits, those buildings are not fit for purpose in terms of doing that. So I definitely think we should write to NHS England and indeed the Secretary of State.
Okay, maybe not the Secretary of State, maybe a follow-up comes to the Secretary of State, because I would like NHS England to respond rather than the Secretary of State respond. But can we, I'm not aware of this Patricia Hewitt piece of work that you're talking about, so if we can take that outside of this discussion and just have a further discussion from there. What are other members, and indeed, what is your view, Richard? My view would be that we've obviously got to draw out of what we can
from it to ensure that we're aware of what's going on and so forth. So to obviously write to the NHS England, I think is absolutely right and proper to try and get that answer from them, which will help us make a help. And then in time, certainly, if the answer is not satisfactory, then I think that's exactly when we then move forward to the Secretary of State or Minister of Health. So, but I think it's probably right. We want to be careful, obviously, what the remit was initially of the working group, and we're not then creating ourselves additional that was not the working group's initial remit. So we've got to be careful where we go with it to ensure that we're not overstepping, not say overstepping, but delving into something that actually was not asked for us to do. But at the same time, within its remit, I think that's probably fair to say that we should be able to do.
Thank you, that's useful. Does anyone else have any further views? I certainly agree about mission creep, or scope, the scope creep, or your terms of reference creep. Are we in favour of that proposal? I would just say we ought to just take some soundings from the ICS and make sure that there's nothing that we're doing that would upset the position with that, providing there is money coming into Staffordshire. I think that's what we're all after. Are we in favour? Thank you, Claire. Claire, useful discussion, because I think that sort of crystallised where we are, and thank you for the work that you're doing. And obviously, we look forward to seeing the detailed business or the outline business cases, as you described, coming forward to us. Thank you. You're welcome to stay, you're welcome to go, but otherwise I'm going to move on to item number 7. So item number 7 is the District and Borough Health Scrutiny activity. I was just going to make one suggestion which on the paperwork, which is if we can keep the paperwork so it relates to health stuff, that would be very helpful. There's lots of stuff in there, and some of it doesn't specifically relate to health. So maybe if we could persuade officers, district and borough officers, to only send us what's relevant, that'd be helpful. I was going to open up with Mike first, and I need to just give you an update as well. Under the previous meetings, Developing Healthier Communities, we've had an executive response relating to the recommendation which was on the committee. The committee agreed at the last meeting back at the end of November, and the executive response is as follows, ad verbatim. The key will be for districts and boroughs to review the recommendations of Developing Healthier Communities in the context of their own organisation or locality and determine how they want to proceed. Staffordshire County Council's public health officers are available to help shape these plans and provide advice and guidance if needed. Is there another bit down to this? I also want to make sure members are aware that a paper has been submitted to the District Chief Executives Group on the 26th of January last week. The paper was sponsored by Dave Hayward and Tim Clegg and included some similar recommendations for high-impact action on health inequalities, one of the Leaders Board's priorities, which will tie in with the recommendations identified here. And there is a suggestion to review the district and borough district and borough representatives and for them to raise the recommendations in the report with their councils to review the recommendations in the context of their own organisation. Now, I just want to bring Mike in on that basis, please.
Thank you, Chair. Yes, I did go back and we had a conversation with my overview and scrutiny committee, and also with the leader and the chief executive who happened to be present at that meeting. And yes, we are going to formulate a plan, and we've got it to go into our work programme post-May. We do see a big part for this field to play in the health equalities and having a health profile in all that we do, and making sure that it does play a key part in our strategies going forward as the plan for the local council. So we will be reporting back on that once it's in our our work programme, and we'll update this committee as to any work that's ongoing. We appreciate the support that's given by the County Council. We may well use some of the officer support, and equally, the Chief Exec and the Leader are both 100% behind this, and think that it is something that we should embed into everything that we do to make sure that we're playing our part in keeping our communities healthy. Thank you.
Really useful, thank you. And I think you make some really good points, powerful points. First of all, you know, to review the forward agenda annually is a really good thing to do, and that opportunity is coming up very shortly. And obviously, I think people can reflect on this morning's discussion on item number 3. Charlotte.
Yeah, just really to say how disappointed I am by the report on the Stafford Moorlands meeting. To say that we had a presentation from Mark Doherty would be to completely ignore the devastating nature of the statistics he gave us, and the fact that he said he'd resigned his post. You know, it was absolutely devastating that clearly the ambulance service was completely failing to get to Category 1 and Category 2 appointments or calls within a time to be able to have any chance of saving life. I mean, I think he at one point said it was quicker to order a takeaway pizza than it was to get an ambulance. And particularly if you're in an outlying area, there was just no chance that an ambulance would get there in 8 minutes. And some of the figures that were in front of us just demonstrated people waiting literally hours and hours, even if they were a Category 2, by which point, if they'd had a heart attack, they'd be dead. And it's just to have that sort of comment there. We had a presentation in no way recognises the really devastating information that was given to us at that meeting. Absolutely mind-bending.
Thank you. I note your comments. I'm just going to go in a different direction, which is there were several elements on this report. First of all, West Midlands Ambulance Service, because in my view, that's a county scrutiny function. And accessing primary care face-to-face. Again, I would probably say that's a county function. We've got to be really careful between all of us that we don't mistake the terms of reference of our individual committees and this committee. I know that's not quite the point you were making, but I do think that we need to be, maybe call in some of the things that shouldn't be on other committees' agendas, because one of the learnings from Francis was really clear that there was scrutiny that was missed, and it was double done, and we just need to just maybe think about that again. I should just mention that the Leaders Board is going to be re-looking at the terms of reference of this joint committee. It's not a wholesale change, it's just tightening it up. It's a review that should be done every couple of years. It's going through the Leaders Board. Does anyone else want to pick up anything else off? No? Good. I think we're making broad progress towards having an aligned policy between districts and boroughs and the county, and equally the health service, so I think that's welcome news. So I'm just going to move on to the final item of this morning's meeting, which is the work programme. It's all in front of you. It's all as recorded. Is there anyone who wants to make representation in terms of the sequencing? I have mentioned this morning I would like to make a recommendation that we bring back the system, which picks up Charlotte's point, to talk about the lessons learned from the crisis that we've seen within the health system over the last 6 months, particularly in terms of ambulance waits. That's the front end of the system. So I'm going to suggest we do that in probably May or June.
By that time, Patricia Hewitt's independent review of the ICS would have been published, so that would be mid-March, so that would be a good time.
Thank you, I appreciate that. And I've been given some meeting dates.
Yep. Through you, Chair, it's just the proposed meeting dates for next year. You were talking about bringing back the system items. It could be on the 12th of June or a July meeting.
If committee are happy, I'll take representation from the NHS when is the best time out of those two, because what I do want to see is where the hard wiring of any lessons learned into the forward plan for next winter, if that makes any sense. Are we happy with that as a recommendation? Thank you. And on that basis, not quite record time, but 12:10. Members, have a great afternoon. Thank you for your contributions this morning. We will catch up in 2 weeks' time. Thank you. I can't wait.